Thank you, Dr. McCormick. You're doing the hard work of building a suicide prevention and life promotion strategy in Indigenous communities, where your focus is on connection, culture, and keeping people alive. But at the same time, the broader system is moving toward offering assisted death for those very same mental health struggles. In communities where decisions are deeply connected to family, culture, and future generations, that seems like a very confusing message. So how do you explain that to the communities you serve, that you're working to prevent suicide on the one hand, while the government is expanding access to state-sanctioned death for mental health conditions that your strategy is designed to address? Oh, you're on mute.
Yeah, you're right. There's that conflicting message. I don't have any answers. I think yeah, I don't have any easy answers to that. Why one system is pushing for one thing and why another. I mean, the culture is not. It's just not. It's not the way we operate on an individual basis like that. Yeah. So good point. I don't really have an answer to it.
And many Indigenous leaders have spoken about how past systems opposed outside values and decisions onto their community, often without fully respecting those cultural frameworks around life, responsibility, and care. And when we look at MAID, it's built largely around individual autonomy and personal choice. But that's not how many Indigenous communities understand decision-making. It's often relational, tied to family, community, and future generations. So do you see a risk that expanding MAID, especially for mental illness, could reflect a similar pattern of imposing an individualistic framework onto Indigenous communities?
Yes, definitely. I got that right. It's in that cultural conflict, the focus on individualism, I think it's one of the reasons why there is mental duress and struggles by people, because it just adds to the pile that the media and everyone, the health system, educational system is saying, no, you have to be an individual. You have to master your own environment. It's a very biased and culturally encapsulated view of how you should function in life, and that goes against a lot of community, family, traditional values.
I attended a Métis Nation BC presentation where Dying with Dignity was presenting MAID as essentially another treatment option, framed as compassionate and loving. But at the same conversation, Shirley Sullivan, who was a Métis nurse practitioner, pushed back and said clearly, MAID should not be the alternative for a lack of services. Because when a system presents death as a solution in communities that are still fighting for basic access to care, it's not a choice, but more like something being introduced into a gap. So from your perspective, is there a risk that framing MAID this way, especially where services are lacking, reflects the typical pattern where outside systems and values are being layered onto Indigenous communities instead of addressing the underlying needs?
Yeah, absolutely. Yeah, when we're given those messages, it's more of the same, it seems. Yeah. I'm sorry, I wish I could give a more optimistic answer to your questions, but I totally agree with what you said.
So in your estimation, how many Indigenous Canadians suffer from a mental illness and could be at risk of MAID with this expansion?
I don't have stats in front of me, but generally we have higher rates of mental illness, and certainly that's reflected, some of the symptoms in terms of addictions and incarceration and the suicide rates. I mean, it's 3 times higher. It's much, much higher for the North and remote communities, for Inuit, for males versus females, but it's still a shocking discrepancy between what the rest of Canadians experience.
Yes, and we're definitely hearing that from professionals. It's a really a regional problem where, certain areas you can get access, many areas you can't. So I appreciate all the work you're doing. Thank you.
Thank you.
Ms. Jensen, Mr. Grant for 5 minutes.
Thank you, Mr. Chair, and I want to thank all the permanent members here for the work they're doing at this committee. It's a very important topic, and thank the witnesses for coming forward. Mr. Belanger, Dr. McCormick, my name is Wade Grant. I'm from British Columbia. I was actually formerly the First Nations Health Council Chair, and I know that both of you have had interactions with the First Nations Health Authority. I grew up on a First Nations reserve where many of my relatives died way too young because of suicide and other things, and we know far too often First Nations and Indigenous communities will have to put forward a state of emergency because of the overwhelming amount of people, especially the young people who, in your stats, it's the number one cause. Suicide is the number one cause of Indigenous youth and those under 44. It's 9 times higher in the Inuit community and 3 times higher for First Nations and 2 times in Métis. As I grew up and went through that, it shows that the people are not getting the treatment that they're searching for, and you've said this in your statement today, Mr. Belanger. And I'm just wondering if you know why. Will you explain a little bit more about how their needs are not being met or being partially met, and also what comes into play when people actually don't seek it because of the mistrust they've had for health.
Sure, and thank you for the question. And in a former life, I was the executive director of health for First Nations in the North. We put in programs. We had an epidemic of suicide crisis in the northern BC. We worked with 4 nations to put together programs to try to address those things. The unfortunate aspect is that funding within First Nations communities is often inadequate to deal with mental health issues, to deal with home care. There's very limited disability-related funding that is provided, and access to clinicians is very difficult. You look at 6 months to a year too longer. In northern communities, even longer than. The distrust that's been, with government and government agencies still exists as well. Anti-Indigenous racism in Canada has gone up exponentially over the last couple of years, and racism within healthcare is rampant. We know the cases of Joyce Echuan. We know Keegan Combs. We know about the In Plain Sight report. So there's all this apprehension to go out and seek something outside the community where your family is, where your supports are, where you are, part of a community where in other communities and systems that you may not even be welcome to. So again, has been noted, limited economic opportunities within communities, limited infrastructure. Some communities are dealing with massive housing problems. And again, the whole thing is the lack of availability of mental health services. And it's a struggle that has continued for a long time.
Thank you, Mr. Belanger. And Dr. McCormick, you'd mentioned that Indigenous rights is a collective right, and sometimes we far too often look at the individual right. And when I was on the First Nations Health Council, we issued the 10-year strategy on the social determinants of health, which was adopted by 84% of chiefs of 176 chiefs. Back in 2023, and we talked about the community-driven, nation-based approach, and that's that's the two-eyed seeing approach for First Nations to be able to make sure that the health and well-being of their people comes home to them. Maybe you can expand a little bit about the work that you've done on that and how that's working when First Nations culturally sensitive and traditional ways of healing have been brought forward.
Yeah, there's been a growth of movement towards traditional healers and healing and ceremonies. A number of the health centers in BC have traditional healers as part of their staff. Ceremonies have been so valuable in people's healing. Those are being brought back. So there's hope for the future, but a lot of it is what we have to do ourselves as Indigenous communities. I'm a researcher, and I often say research is the search again for what we once knew, because we had some really good systems in place before colonization, and we've tried for years now to get help, both from federal and provincial governments and organizations, and a lot of money has been spent, but not a lot of help's been provided, it seems. So I believe that the secret is community empowerment, community engagement, ownership, and self-determination in many ways when it comes to mental health services. We obviously we're going to need some finances to do that, but I think we have to find the solutions ourselves because it's government just hasn't been able to do it for us.
Thank you, Dr. McCormick. Madame de Bellefeuille pour 5 minutes.
Madame de Bellefeuille for 5 minutes. Thank you very much, Mr. Chairman. My name is hard to pronounce for an Anglophone. There's many vowels in it. I wish to thank the witnesses for their testimony today. I'm a member of Parliament that represents the Mohawk community of Akwesasne, which is within my riding. Because I was sensitized to this issue by the chief, there's a lack of social services and health services, not just mental health, but the whole field of health in these communities. And I would say that there's even addiction problems because of opioid addiction. These are very acute problems in our community. We've discussed it. We deplore the fact that Indigenous communities are not supported better to face these health issues, which are significant. In all provinces, including Quebec, there's a lack of funding, a lack of support in all health sectors. That's why we say that today we would have liked to see in today's economic statement new money to be invested in healthcare for people who need it in our communities and in public services of the provinces in general. We were disappointed to see, we even saw cuts within the next few years of the transfers for health and social services. So I can't disagree with you about the fact that there's a lack of services, but we have to broach the subject of MAID. You use the term euthanasia. I don't know if I interpreted badly, but in clinical language or legal language, we talk about medical assistance in dying, not euthanasia. MAID is a request that comes from an individual who's making a decision to choose a method of dying with dignity. So there's palliative care, there's MAID, there's many different aspects to it. There's lethal injection. It's one of many different choices in MAID. So it's not imposed. It's not, I really don't see how this kind of care is imposed on a community. It's offered, and full-fledged individuals can make that choice. So my question, because I'm not a permanent member of this committee, I have not heard all previous testimony, but I really want to better understand and I want to learn. Can you tell me whether, for example, there are many people in your communities who have an incurable, persistent disease such as cancer or MS or something else? In your communities, do they request MAID to get relief from their suffering and die with dignity? Or is this something that you do not request because of your culture or your way of broaching life, let's say?
So for our organization and for me as the CEO, we deal with disabilities and we're dealing with Track 2. So I don't know the frequency of within the Gitxsan Nation or any nation of how many people might be requesting MAID or taking MAID under Track 1. I haven't heard any from my chief or the members in my family. Doesn't mean it doesn't happen, but I just don't have that expertise. And to go back and respectfully, I mean, listen to your comments and I appreciate them, I do. But medical assistance in dying is a euphemism that was put in place it's non-culpable homicide in the criminal code. That's what it is. So, and this is part of the process of making something where we have, Indigenous and non-Indigenous people with disabilities that are burdened down by the pressures, the lack of services you just described, where they are to a point where they are, making a decision, which I believe is coerced, even though people say it is a decision that they make themselves. But when you have all these pressures of everything else, so
I don't want to interrupt you, it's impolite, but right now, MAID for people with mental health disorders is not accessible. We're discussing whether it should be broadened. Right now, MAID exists for physical health problems such as cancer, when there's predictable end of life. So what I'm asking is whether that kind of care is requested in your communities.
sorry.
You just have a very short time. She's gone through her.
Again, under track 1, I couldn't give you that information.
Thank you. We'll go on now to Senator Delphone for 3 minutes.
Thank you very much for the members of the panel. My question will be for Mr. Belanger. First, I recognize you came before us in 2022, and we worked together to have the recognizance of the awareness, the Indigenous Disability Awareness Month, 9 years, well, almost 12 years ago now. So you've been involved in that for long. At the time when you appeared before us, you said in 2022 that the federal government had not consulted with Indigenous groups and nations before pushing for MAID. And you said that, you thought it was not really UN declaration compliant or the UNDRIP Act now. So, but since 2022, was there some consultations with the Government of Canada or the Health Canada and the Indigenous groups?
There has been. I think in 2024, I think it began, or 2023, I'm not sure of the dates. But Health Canada started to do an online consultation and provided some funding to different disability groups to, I think it was called End of Life, the Indigenous perspective there. So although it happened, the online report, as I'm sure you know, Senator, it was on for a year. It had to be extended because of lack of uptake. And at the end of the day, they had 250 respondents across Canada, 50 of which that they eliminated. The population of Canada in 2024 was 1.8 million that identified as being Indigenous. So the respondent rate was like 0.001222%. So, I guess you could consider that a consultation. I don't know if it's that valuable. We actually met with Health Canada in relation to that. We gave them a 6-page document about our concerns about the online consultation. We had a meeting with them as well to address our concerns. It was a cordial meeting. I wouldn't say it was a productive meeting, but it was cordial. And they offered us, the possibility of having a contract to do more consultations. We asked that if we did that, then we would talk about the history of the AMED committee. We'd talk about the recommendations. We'd talk about the implementation of MAID, including recommendations for mature minors and advanced directives. And I know that's not part of what we're looking at today, but we wanted to give the whole view for our communities and for the people that we serve so that they have an informed knowledge, so they can answer questions with an informed, more informed than what the survey had provided. We never got a call back.
Sorry to interrupt, there's almost no time left, but at the time you were also stressing the fact that you had difficulty to access mental support and did the situation has improved for the Indigenous communities?
In accessing mental health services?
Yes.
I don't think so, no. Not from our experience as a service provider, no.
Thank you.
Thank you, Senator Delphone. Senator Moody for 3 minutes.
And I'd like to thank Professor McCormick for sharing your areas of research with us and for helping us understand all the work you've done in the past. I'd like to ask you 1 or 2 questions around this work. Would you agree, first of all, in terms of helping me understand, that there are Indigenous peoples and communities across them, they hold quite a wide range of views on MAID, that in fact Indigenous peoples there are Indigenous people who request, who have been found eligible and who have received MAID, that this is happening on reserve and in communities. and that there are Indigenous MAID assessors and providers in Canada. Are you aware, and would you agree that this is the existing situation right now in Indigenous communities here in Canada?
Yeah, I as my colleague mentioned earlier, the report that was done looking at the experiences of Indigenous people in MAID, it pointed out that a lot of people didn't know about it or had very little knowledge about it, so it was easy to get confused. I think that was one of the findings. Certainly, it does exist.
About you
and
your knowledge, yes. Are you
yes,
you're aware of this, right? Correct?
Yes.
Okay.
Yes.
And I'm just following up. You're aware that there are Indigenous people and providers who believe that exclusion of MAID for mental illness alone is wrong, that they are being deprived of a service. Are you aware of that?
I'm not aware of it, but that makes sense. As you
Okay.
say, there's a lot of diverse opinions. So yeah.
And I guess the final question I have, and this is easy day for you, have you done any specific direct research, studying, consulting with any Indigenous individuals who have wished to have MAID, any assessors or providers who provide the service? Have you done any population studies yourself? Is this an area of research that you have intersected with yourself?
No, it isn't. I've done work in the past looking at suicide recovery amongst Indigenous patients, but not specifically for MAID.
Thank you. End of my question. I cede my time.
Thank you, Senator Moody. Senator Osler for 3 minutes.
Thank you, Chair, and thank you to both witnesses for being here today. And my question is for Mr. Belanger, and it follows on the questions that Senator Delfond had asked about consultations with Indigenous communities. And I take it from your testimony that the level of consultation with Indigenous communities was not sufficient. So my question is, what measures would you recommend to the Government of Canada so that meaningful consultation with Indigenous communities on extending MAID to persons with mental illnesses as sole underlying medical conditions meets the standards set out in UNDRIP?
Well, the UNDRIP called for the total repeal of Track 2 MAID, and including the mental illness as a sole underlying condition. So there are no recommendations that I would make to anybody, because if we are going to be consistent with our obligations, our international obligations, it should be removed. We wouldn't have to have a conversation. My recommendation is that we provide quality, adequate, and timely services to persons with mental illness as the sole underlying condition, to persons, Indigenous people with disabilities. That's the only recommendation I can make. I can't make recommendations where irremediability is so divided among clinicians to say, how do we make this more culturally appropriate? How do we make it fit for your community? It wouldn't make sense to do that. We need to act upon the recommendations of the UN. We need to repeal it, including mental illness of the sole underlying condition, and get people the support they need to thrive in their communities, without exception. And there's multiple areas that have to be addressed. It's not just access to mental health services, it's housing, it's conditions of poverty, it's isolation, it's all those things that I'm saying are stacked up and stacked up and stacked up. So no, there's nothing I would say that could make this, or I would say that I would want to see this be a reality.
Okay, so just so I'm clear, you're saying no further consultation at this point?
Well, I'm saying that I'm hoping this committee will make recommendations based upon what the UN has said, based upon information from the last committee, based on from information we've heard here, that we'll honor the UN and our obligations to them, and make recommendations to repeal Track 2 MAID, including mental illness as a sole underlying condition. I can't make recommendations of things that in the future. We have to see what the recommendation from this committee is going to be, and what we're going to do moving forward. Then I can make recommendations, but it will never be to euthanize individuals dealing with mental illness as a sole underlying condition, or persons with disabilities when their basic needs aren't being met. And that shouldn't be, respectfully, anything that this committee should be endorsing as well. We need to deal with the problems that are here today and the deficiencies within the system. This is nothing new. This is a fight that we've been doing for years, as long as other organizations as well. And, you know, the reward for living a life of inadequacy and lack of access to services shouldn't be, you know, what people have described as a dignified death. We need to have dignified lives where people get the support they need to thrive.
Thank you. Thank you, Mr. Belanger. Senator Wells for 3 minutes.
Questions to Dr. McCormick. If you could just clarify me, I'm not sure I heard you correctly when you did your introduction. Are you with Indigenous Disability Canada?
No, you. I'm a professor at Thompson Rivers University and a research chair.
Okay, thank you. So maybe I'll go back to our other witness. Thank you for clarifying for that. And I think you've already clarified some of this. So your position is that Track 2 should be fully eliminated?
My position that any law in the books that targets a chartered protected group should not be on the books.
And is your organization a plaintiff in the chartered challenge to Track 2 currently?
We are.
Okay, thank you. My question to Dr. McCormick then. I think it's safe to say that everyone at this table agrees that every Canadian should be provided with adequate supports, whether it's financial or emotional, to help them with dealing with mental illness. But a majority of the witnesses at this committee have made the false equivalency between requesting MAID and having suicidal ideations. So being approved for medically assisted death and having suicidal ideations are two different things. So, Dr. McCormick, if somebody who has a mental illness is genuinely seeking MAID or additional information on the MAID process, how do you suggest suicide prevention frontline workers address these questions? And for the record, I want to point out that to receive a medically assisted death in Canada, a person has to be eligible under strict rules laid out under the law, and they have to go through a rigorous process for multiple medical professionals to deem them eligible for MAID.
Yeah, the last part you said, and again, I don't have data in front of me, but from what I've read, the safeguards just aren't really there. I mean, my understanding, and perhaps you can correct me, is people can choose whether they've exhausted the options for treatment. They can make their own decisions. Say, no, I don't want any of the talking therapy. I don't want this. I don't want that. I mean, I think there's so many new options out there because I work in the field of trauma recovery and so on, like EMDR, psilocybin-assisted psychotherapy. We're coming up with new approaches all the time.
If somebody was coming to your organization then in the suicide prevention, how do you suggest your frontline workers address questions if somebody's coming to you and inquiring around MAID?
Well, my field is counseling psychology, and we spend a lot of time talking to that person about different options they have. It would be a lengthy process. I mean, I'm not sure what, I think it really varies in terms of MAID assessors as to how much time is spent finding out their story and what they've tried, what they haven't, what their resources are that they have, what the threats are, protective factors. There's just so much that goes into working with someone that wants to die. And I'm not sure that
Thank you.
Would you refer them to Indigenous MAID providers?
Senator, your 3 minutes is up. Thank you. We go to the second round of questioning. Mr. Patzer for 3 minutes.
Thank you very much. And before I begin, Mr. Chair, I just want to highlight that I think it's completely inappropriate for Senator Wells to call people he disagrees with liars at this committee when we have had. Yes, you did.
Order.
Yes, you did.
I did not say those words.
Yes, you did. You said the majority of witnesses in this committee were lying in regards to suicidality.
Mr. Patzer is using up his 3 minutes. Is he pleases? He's on the clock. Go ahead, Mr. Patzer.
Thank you, Mr. Chair, and I will let my comments stand. Mr. Belanger, in regards to your comments you're making about the United Nations, has Canada formally responded to the recommendation that you were alluding to?
They haven't, no.
Okay, and we've been hearing from witnesses already about the Werther effect and the issue of suicide contagion. We have responsible reporting guidelines for media coverage of suicide that the entire suicide prevention field follows. So what is the contagion risk in Indigenous communities, specifically when government legislation says death is a valid medical response to mental illness?
I think it's quite high. And again, back to my life as running health, and again, the suicide crisis that I went through, we worked with 4 different nations because they were experiencing similar things as well. One of the nations said that we were no longer going to have celebrations of life because it highlighted the person's suicide, and other youth and people in the communities wouldn't then do that because they saw that as a celebration, people getting together, recognizing that person. They said, no more, we're not doing that anymore. And I think when you portray MAID as, and again, track 1 and track 2 get intertwined all the time, but the stuff that you see online often, and you see, I was there and I was drinking champagne and I was doing whatever. It's not the reality for most persons and persons with disabilities living in poverty, but it gives a message that this is a good escape and this is a way to go, and this is some kind of justification for a life of wanting and not having supports that the end is somehow dignified. I don't think that's true, but I think certainly it influences, to be sure.
Thank you for that. And then you've now sat through about 3 years of these committees. What do you want this committee to put in its report so that 2 years from now we're not back at this table asking why more Indigenous people with disabilities or mental illness have died because we expanded a system that we knew was broken?
I think I would hope the committee would say, look, we've taken a look at this and we've looked at the law, and it's targeting, persons with disabilities, individuals with mental illness as a sole underlying condition. Take a look at the spring economic statement today, and look at the lack of services and funding that has been put in that too. We have to make changes in Canada to make sure that we're supporting persons with disabilities, individuals with mental illness as a sole underlying condition. This is not a progressive move. It's not an equality right. It's ignoring our responsibilities to our most vulnerable, and we're normalizing this. And once it becomes more normal, we will never get it back. And there will be no government that will come back and say, "Oh, let's make sure that we're adequately funding this," because it also has become this acceptable alternative to proactive, timely, and adequate treatments, supports, and services. This is where we are today, and we need to stop it because it keeps going forward. It's not going to stop. And we've seen laws in the past that have been on the books for 50 years where Indigenous people have been targeted and things have happened. It took 50 years to get past it, even then after they're off the books, to deal with it, and we're dealing with those today. We shouldn't be in this situation. Take it back. Give the support people need.
Madame Brière pour 3 minutes.
Ms. Brière for 3 minutes. Thank you very much, Mr. Chairman. I wish to welcome both our witnesses. Mr. Belanger, I heard your answer to the preceding question. I agree with you that improving access to care, improving housing conditions, there are many things, no doubt, that we could work on to improve the situation of people in their day-to-day lives. But do you think that when a person requests medical assistance and dying, they get it automatically?
I'm sorry, getting MAID automatically?
Yeah. If you ask MAID, do you think that you automatically get it?
Well, I guess it depends on what tracks you're doing, but under track 2, there's a 90-day waiting period, right? And during that time, the assessment period for the person to think about it, hopefully they're getting programs and services recommended to different disability supports, but that really doesn't happen. I mean, that's the thing. And in my case about the individual being approved for MAID, but not even being referred to get their disability tax credit. So no, I don't think it happens immediately. I don't think it happens like right now and that type of thing. I think in some cases lines can be.
I'm sorry, I'm not talking about a span of time. I'm just asking you, if someone asks MAID, do you think that he will get it?
If somebody requests MAID, do I think they'll get it? What? Automatically?
Yeah.
Well, I would hope not. No, I don't think that happens.
I think it will.
No, I don't think that if you just walked in and asked for MAID that you would automatically get it. No.
Okay. J'aimerais alors vous entendre.
Therefore, I'd like to hear you again on the integrity of doctors who assess people, who evaluate a file, and who approve or not a request for MAID.
The clinician, by any sense, I would defer to the clinicians that spoke here, both who are for it and both who are against. There's no consensus on it. So, I mean, if there's no consensus, and I'm not sure what percentage would be acceptable. If 80% thought that it wasn't irremediable, is it 40%? What's the acceptable amount of people that might be euthanized that could have a better life? For me, it's zero. And unless there's 100%, agreement on this, we are running the risk of euthanizing people that could have led a good life. And that's not a risk that I would take personally, because I know the damage it does to families and everything else that have to go through this. So I'm not debating the credibilities of the clinicians, but just the simple fact that they're so divided should give pause to this committee to say, what are we talking about? There's no consensus here, so how can we push forward a law or expand it to something that nobody can agree to? It's not like... Sorry.
Thank you. Je vais essayer encore. Madame.
I'll try again. Ms. de Bellefeuille, is that better? That's perfect, actually. Thank you, Mr. Chairman. So, Mr. Belanger, please excuse my lack of knowledge of this whole Indigenous issue, but I'm curious by nature. I want to understand. I want to learn. When you speak and represent your group, is this demand you've made to withdraw Indigenous communities from MAID is a motion? Is it a decision by all First Nations and the Inuit? Is this a demand that is meant to exert pressure on the government, or is it more your opinion as a representative of the group for whom you're here today? As a member of parliament, I never got any communication with my Grand Chief who asked to be withdrawn from this. So I'm curious, are all the First Nations requesting this, the Inuit as well?
I speak for all First Nations. I don't speak for any First Nation. I don't speak for any of the 53 Inuit community. I speak for our organization and our experience with the people that we serve, who are Indigenous people with disabilities. Our perspective is, of course...
Okay, I don't want to interrupt you, but it's important for me to understand whether this was your opinion, your organization's opinion, or a demand by all First Nations and the Inuit that you're relaying to our committee. But thank you for answering. Professor McCormick, Mr. Belanger didn't have the data on the fact that in Indigenous communities, people are entitled to ask for MAID, which is legal. Do you have any figures about that? Is there a trend? Do Indigenous people use that option under the law?
No, I don't have it. I'm not sure if that data is available. It should be, but I don't have it.
Merci beaucoup, Madame.
Thank you very much, Madame de Bellefeuille.
Senator Moody for 2 minutes.
I guess I want to ask Professor McCormick if you have any data whatsoever that sheds light for us on what is happening with the use of MAID in your communities more broadly.
No, I myself haven't researched it. I've read the report that was done, the consultation. That's the data I have, and it was again, there was like one city per province that was surveyed. So it didn't.
So you're not uniquely in a position where you can judge the validity or have a comparative basis on this particular type of data. You've read it like I have, or anybody else. Would that be?
That's correct.
Would that be true?
That's correct. Yep.
And so, is it reasonable to say that you bring a certain expertise today to this committee, but it does not relate directly to MAID? or the use of
Yeah, I
MAID in
bring-
communities that
I
you're
bring
familiar
40
with?
Yeah, I bring 40 years as a clinician working with Indigenous peoples who are experiencing mental illness. That's what I'm bringing to this committee.
Direct connection with that mental illness to MAID, because you aren't able to give us the information of what that connection might be. So I'm asking for it. Maybe I'm not clear in how I'm asking for it. Do you have a connection for us?
No, I don't have that data. I don't even know if it's available.
Thank you.
For the final 2 minutes.
Mr. Belanger, from the Health Canada report published in December 2025 entitled Indigenous Perspectives on End-of-Life Care, including Medical Assistance in Dying, What We Heard, they reported hearing the following from elders, First Nation, Inuit, and Métis people. Number 1, we need to reclaim our death and end-of-life processes. Number 2, when our loved ones die, we should have the right to bring them home. Number 3, I fear losing the ability to decide for myself. And number 4, it is concerning that there's a lot of misinformation about MAID, end quote. So, Mr. Belanger, I agree that colonialism and Canada's systemic exclusion of Indigenous peoples have led to unacceptable rates of suicide in Indigenous communities. If this is what we're hearing, what I quoted to you from the Government of Canada, from Indigenous peoples themselves, how should we then balance these points of view with the removal of MAID that you've suggested here today for Track 2?
Well, I'd like to know, is it from the 200 people that responded to the survey?
It's from the Health Canada consultation they did.
So it could be 200 people of a population 1.8 million. And again, as we've heard, I mean, I'm not denying that there may be people in the community that are supportive of MAID, Track 2 MAID or MAID. But if you'll remember from the previous committees, the majority of the Indigenous witnesses, leadership, persons with disabilities, all spoke against it. So, I mean, I can't comment on a survey that has 200 people of a population of 1.8 million. And to say that this is some kind of tangible document that we have to reinforce.
So just, you don't think the document is credible, produced by Health Canada?
I think that it's lacking.
Okay.
I think that the government should do nation to nation as they're supposed to do and get a good idea about that.
Do you feel that we should, at this committee, have perspectives from Indigenous people who would like access to MAID?
I think this committee should call any witness that they think is relevant.
Thank you, Chair.
Thank you. And with that, I'd like to thank the witnesses, and I would really like to thank them for bringing an interesting cultural perspective to this conversation. And with that, the meeting is adjourned.